Hello, and welcome to the third lecture in this series on endocrinology. I'm Colin Diane, Professor of Clinical Diabetes and Metabolism at Cardiff University School of Medicine. So this lecture is going to be about diabetes and associated hypoglycemia with some electrolyte abnormalities. Let's go on to the first question. So a 42-year-old man with a 30-year history of type 1 diabetes comes to the clinic complaining of frequent falls. On 2 occasions he's fainted and knocked his head and had to be taken to the emergency department, and at other times he was dizzy and had a short period sitting down, improved things for him. He has a history of peripheral neuropathy and erectile dysfunction. He takes a basal bolus regime involving insulin glargine and mealtime Novorapid. He also takes Ramipril 5 mg a day for renal protection and indapamide 2.5 mg. On examination, his blood pressure is quite well controlled, 145/80, with a postural drop, though, of 35 mm systolic. He has signs consistent with peripheral sensory neuropathy to the mid-shin. Here are his investigations. I'll let you look at those for a moment. And the question, which one of the following is the most appropriate next intervention? So there are 5 options for you to look at. And the best answer here is to stop the drug, the diuretic indapamide. Let's go back to the question and see what the key points are here. So in the history we have long-standing type 1 diabetes and this unusual presentation of falls. When you look at the falls, they seem to be posturally related. He's dizzy, but he feels better when he's sitting down. And that fits with lower down when he's got postural hypotension. So that seems to be the key issue. And of course here he's on drugs to treat hypertension, the Ramipril and the indapamide, but that's because he's got renal disease as well. When we come to the investigations, we see that he's got a relatively high potassium, a slightly raised creatinine, and he's also got an HbA1c measured in the new units of 50 millimoles per ml. And in fact, that's quite a good level of HbA1c. So when we come to the interventions, we're thinking about postural hypotension. So in thinking about the postural hypotension, we're unlikely to benefit by reducing the prandial insulin, option C, or reducing the background insulin, because this is probably not hypoglycemia. So we could use elastic stockings, but one of the key things is we don't want him to be volume depleted. And that makes us focus on stopping the indapamide, although we've got this problem that we want renal protection in there as well, so we're going to leave the ACE inhibitor, which may be contributing to his slightly high potassium. A later option is to introduce fludrocortisone, but this is going to raise his blood pressure and antagonize the effect on the kidneys. So the best option here was to stop his indapamide. So now let's look at the new units for HbA1c. And on the slide here, you can see the DCCT-aligned HbA1c, the one you're probably familiar with in percent, and the new units from the IFCC in millimoles per mole. As a trick on how to convert, it's not so easy to think about how to convert. I've given you a few conversion tips along the bottom. My own rule is if you take a whole number of percent, you can use the -2 rule. So if you start with 6%, if you do -2, that's 4, -2, that's 2, that gives you 42. And when you start from 7%, -2 is 5, -2 is 3, so you get to a number of 53. And the same is true for 8%, or 9%, or 10%. Another way of looking at it is once you start with 6%, which is the cutoff for impaired glucose tolerance, if you know to convert that to 42, then every whole percentage up from there is 11. So you'll see 7% is 53, 8% is 64, 9% is 75, and so on. And then the 2 figures to particularly remember in the new units are 42, which is the diagnostic criteria for impaired glucose tolerance, and 53 or 7%, which is the target for good glycemic control. So in this case, the value was 50, implying that he actually had quite good glycemic control, possibly too tight glycemic control. Now let's also think about autonomic neuropathy in diabetes, which often comes up in the exam. So it occurs in long-standing and generally poorly controlled disease, so I'm going to assume that this gentleman earlier in his 30 years had less well-controlled diabetes. Manifestations include postural hypotension, which can be severe and very troublesome, making treatment of the hypertension, because these people often have renal disease, very difficult. So you have to adjust the medication, as we've done here, reducing the diuretics. We give them practical advice about rising and then sitting down quickly if they begin to feel dizzy, maybe even lying down, such as in a supermarket. They may have to sit with their legs up in order to avoid fainting completely. Important to avoid hypovolemia. So, for example, if they develop diarrhea. And the use of stockings, support stockings such as elastic stockings, can be helpful to some degree. If that's not enough, and adjusting their medication is not enough, then we might add in fludrocortisone to retain sodium. And there is also a sympathomimetic drug, midodrine, which is not licensed but often used in this circumstance. But often it's not enough to get over the symptoms. Now, these people often have a peripheral neuropathy as well, and that adds to their problems with falls because they don't quite know where their feet are because of their peripheral neuropathy, and they're unsteady because of the postural hypotension. There are other manifestations of autonomic neuropathy. Erectile dysfunction, of course, is very common, and we treat that with PDE5 inhibitors. Diarrhea or constipation can occur, and it's useful to remember that there are other causes of diarrhea in diabetes. In type 2 diabetes, if they're on metformin, that can cause diarrhea that can go on for many years. Statins, which they're frequently on, can also cause diarrhea. But the common cause when they've got autonomic neuropathy is not just a direct effect of the nerves, but the slow movement through the gut results in bacterial overgrowth. And that's an important diagnosis to make because antibiotics will create a dramatic difference for them. Other manifestations of autonomic neuropathy include gustatory sweating. So the patients often report pouring with sweat in their face and in their hair, having to wear a towel around their neck when they're eating. And autonomic neuropathy is associated with increased cardiovascular disease risk and of sudden death, probably because of an effect of autonomic neuropathy on the heart. Let's go on to question 2. A 27-year-old woman comes for her 24-week check at the GP and is found by the midwife to have glycosuria. This is her first child and she has no significant past medical history. On examination, her blood pressure is 110/72 and her pulse is 65 per minute. Examination is consistent with a 24-week pregnancy. Now here are her investigations. And then on to the question. Which of the following is the next most appropriate management step? And I'll let you read through the 5 options. And the best option here is tell her she has gestational diabetes and review after 1 to 2 weeks of a diabetic diet. Let's go back to the question and see what the key points are. So we've got a pregnancy that seems to be progressing very well. Now let's look at the investigations. And you'll have noticed that her fasting glucose is 7.3, which is diagnostic of diabetes. Also notice her HbA1c, and they've been kind to give you both units. At 6.5%, that's a level consistent with impaired glucose tolerance. And notice that she also has glucose in her urine. Now, in order to have got an HbA1c of 6.5%, she must have had a raised glucose, or significantly raised glucose, for some period of time. So it's unlikely that this fasting glucose is a single, random, unusual value. And that's the reason when we come to the best options, that they're considering that you can already say to her that she has gestational diabetes. So if we look through the options here, repeat the fasting blood sugar after 1 week. Now that is a possibility, but I think the reason they're keen for you to get on and treat her is that we have enough evidence that she truly does have gestational diabetes. Review with 1 week of postprandial blood sugars is probably not enough monitoring. We need to begin to get her to do something to lower her blood sugar levels. Arrange an oral glucose tolerance test is not necessary. We've got enough diagnoses and diagnostic criteria here to make a diagnosis of gestational diabetes. As the last option there, tell her she has gestational diabetes and start her on insulin. That's a bit premature because the initial treatment will be a diabetic diet as described in the second option. So let's review some information about gestational diabetes, which is quite common in the MRCP Part 2. Now, in terms of diagnosis, actually the criteria are not universally accepted, and there's much discussion between the American Diabetes Association and the World Health Organization. So I put some of the criteria down here. Strictly, people would say you need 2 or more abnormal values of a fasting more than 5.3, or after 75 grams of glucose tolerance, 1 hour values there of 10 or 2 hour values of 8.6. But NICE has actually used a fasting value of 7.0, which seems rather high, because the 2 hour value at 7.8 is the kind of value you'd see just in impaired glucose tolerance. The Americans use a 100 gram glucose tolerance test, and I put there some of the criteria that they use. Now, we do know from recent studies that gestational diabetes matters, so it's been confirmed that intervention in gestational diabetes improves obstetric and neonatal outcome and reduces macrosomia. But you have to get very normal levels of blood sugar, so the targets are very tight. Screening for gestational diabetes is still somewhat controversial and is not universally accepted, and most authorities suggest you target it to high-risk individuals. Who are those high-risk individuals? As you'll see on the list here, women over the age of 25, women with a previous gestational diabetes mellitus, that's very important because they're very high risk, or a large baby, more than 4.5 kilos. A body mass index of more than 30, and particular ethnicity, and that refers to Asians, Afro-Caribbeans, or other ethnic minorities at high risk of diabetes. Individuals with first-degree relatives with type 2 diabetes. And if you're going to screen, we screen at 24 weeks. But if they've had previous gestational diabetes, you look for it earlier at 16 to 18 weeks. And I put along the bottom there just a reminder that in pregnancy, statins and ACE inhibitors are contraindicated if these people are already on that for other reasons. What about the treatment? Well, we've seen that diet and exercise is the first treatment, but is probably not enough for most people with gestational diabetes. And that might lead on quickly to drug treatment. In the last few years, we've realized that you can use metformin and certain but not all sulfonylureas, particularly glibenclamide, because it doesn't cross the placenta. So some obstetricians are using these drugs, and certainly we don't stop metformin in pregnancy, whereas several years ago we did. However, the mainstay is going to be insulin. And you can use some of the newer insulins, but glargine is not licensed within pregnancy, maybe because it could stimulate the IGF-1 receptor to some degree and cause abnormalities in the placenta. The treatment targets are very tight though. Preprandial blood sugars, that's before meals, are between 3.5 and 5.9, 1 hour less than 8, and 2 hour less than 6.7. So that's essentially normoglycemia. And the reason for this is that even minor degrees of increased blood sugar do result in macrosomia. You don't have to be in the diabetic range. And do remember that after a gestational diabetes pregnancy, the lady's at very high risk of both further gestational diabetes if they get pregnant again, or at diabetes themselves. And the 3-year risk is around 50%. So we recommend a fasting blood sugar should be done from 6 weeks postpartum, and then at least every 6 to 12 months after that, encouraging the lady to take on lifestyle advice, reducing their weight and increasing their physical activity to reduce their risk of developing type 2 diabetes. Let's go on to question 3. A 47-year-old obese man with a history of type 2 diabetes comes to the clinic for review. He is currently managed with tolbutamide, but concerned that he's seen an increase in both his fasting and his postprandial glucose levels. He has suffered an inferior myocardial infarction some 4 years ago and takes ramipril and furosemide for mild left ventricular failure. On examination, he has a BMI of 31 and a blood pressure of 152/82. His heart sounds are normal, and there are mild bibasal crepitations on auscultation of the chest. Here are his investigations. I'll let you look at those for a moment. And here's the question. Which one of the following would be the most appropriate change to his therapy? I'll let you look at the 5 options. So the most appropriate change to his therapy here is recommended metformin? And I think that might be a slightly controversial answer, but it's useful to go through and see how they got to that conclusion. So back into the case, we notice that he's overweight, which would be consistent with type 2 diabetes, BMI of 31. He needs more drugs to control his blood sugars. He seems to have failed lifestyle and, in this case, a relatively mild sulfonylurea of tolbutamide. We notice also that he's got a cardiovascular disease history. When we look at his investigations, we see an HbA1c of 8.1%. And as we know, of course, that will be just over 64 in the new units of HbA1c. He's also got a slightly raised creatinine, hasn't he, and a slightly raised potassium. So what are our options here? Well, what about pioglitazone? Pioglitazone is fluid retaining. This would not be a good idea and might tip him into cardiac failure, so we'd have to be very careful there. Do we need to switch on to insulin? Well, that would certainly reduce his blood sugar levels, but it would put on weight, and we might want to avoid that at this point in time. Acarbose is potentially an option, but not usually very effective. What about sitagliptin? That's potentially an option as well, but it doesn't result in weight loss in the way the metformin does. And in fact, metformin is the only drug that is a glucose-lowering drug and shown to improve cardiovascular outcomes. So as much as possible, we do want patients to be on metformin. Let's look at the indications and contraindications to various type 2 diabetes drugs. So here down the left-hand side, you'll see the medication. Let's start with metformin. So a contraindication here is renal, cardiac, hepatic, or respiratory failures. I usually say any of the failures. And you could argue in this case that maybe there were signs of early cardiac failure, which might potentially be a contraindication of metformin. In terms of creatinine, there's much debate about the cutoff levels or the cutoff levels of GFR, but typically creatinines of around 150 become a contraindication to metformin. But we generally advise you should try to hold on to metformin for as long as possible, as it seems to be the best drug in type 2 diabetes if people can take it. Notice that you have to stop it when people are given X-ray contrast media, but remember to restart it 2 days afterwards. The main side effect here is diarrhea. The sulfonylureas, contraindication is people who already have episodes of hypoglycemia, and also they are renally excreted, so they're contraindicated in renal failure, except possibly tolbutamide, which is only mildly renally excreted, mostly inactivated in the liver. The main problems there are hypoglycemia, and they result in weight gain. The glitazones, and certainly one of them, rosiglitazone, has recently been withdrawn because of cardiac side effects. They result in fluid retention and cardiac failure, and they also, in fact, increase your risk of fractures. This is probably an effect on the osteoblasts. And common side effects are fluid retention, weight gain, and we mentioned their fractures. So in terms of the gliptins, these are newer drugs that act on the enzyme DPP4. And a contraindication is renal impairment, and they have a strange side effect of nasopharyngitis. The final drug on that list is GLP1 agonists, and they have a mild or rare risk of pancreatitis and are contraindicated in severe renal impairment, and their main side effect is nausea. They could have been an option in this case, but we weren't given that option in our list of drugs. Question 4. A 22-year-old man comes to the clinic with his girlfriend. His GP has recorded an abnormal fasting glucose and wonders if he may have underlying type 1 diabetes. The patient actually reports no significant symptoms apart from recurrent penile candidiasis, which he and his girlfriend normally manage with fluconazole treatment. There's a family history of polycystic liver and kidney problems and diabetes, but nil else of note. And on examination, he's slim with a BMI of 21 and a blood pressure of 132/71. There are no significant abnormalities on physical examination. Here are his investigations. And on to the question. So which of the following is the most appropriate initial therapy for this man? And here are the 5 options. And the preferred answer here is glycoside. How did we come to that? Let's go back through the question. So it's a young man, and what's interesting about it is that he's slim. He's got a BMI of 21. He does seem to have diabetes because he's got an abnormal fasting glucose and he's got candidiasis. So this suggests that he probably does have true raised blood sugar. Let's have a look at the investigations again. And you can see on the bottom of the list, they have given us an unusual investigation, fasting C-peptide. C-peptide is the fragment that's cut out of the insulin molecule when it's secreted. So it gives us an idea of the amount of endogenous insulin that's being produced. And you'll see that the value they've given is 1.4, and helpfully they've told us for typical type 1 diabetes, the value should be less than 0.4. So this is a raised level. This gentleman is still producing a significant amount of insulin. And when you've got an individual who has a family history of diabetes, the renal and hepatic manifestations of cysts, which is unusual, and although he should appear to have type 1 diabetes but is still making quite a lot of insulin and has no history of ketosis, you need to think about unusual forms of diabetes, particularly maturity onset diabetes of the young, or MODY, as you'll see on this slide. So I put across the top, consider this diagnosis, which is relatively rare, in individuals not requiring insulin but are nonetheless slim, particularly if they're Caucasian, under the age of 25, and have a positive family history of this kind of diabetes. Now, there are many different forms of MODY that have now been identified, but I'm going to focus on the commonest 4 of a relatively rare set of conditions. MODY1 is an abnormality in a transcription factor HNF4 alpha, and I've pointed out that it's similar to MODY3, so we'll come to that in a moment. MODY2 is an abnormality in glucokinase, and this is the enzyme within the beta cell that senses the level of glucose. So essentially what happens is the beta cell doesn't sense the normal level of glucose, and the whole system is reset to a higher level. So the patient has a raised glucose, but it never gets very high. They can secrete insulin when it gets a little bit higher, and we get a mild form of diabetes, which is relatively non-progressive with a very low risk of complications because the levels of glucose never rise that high. Importantly, in general, no treatment is required. MODY3, however, is much more like common garden diabetes. It's due to an abnormality of another transcription factor, HNF1 alpha, and it is the commonest form of MODY, around 60%. It is progressive, and that means that although diet might help to begin with, soon medication is required. But one of the great advances in the people who studied MODY is that they discovered that these individuals are remarkably sensitive to sulfonylureas. So when they're given drugs such as glibenclamide or glycoside, they have an impressive response. They can still make insulin in response to the sulfonylureas. And it's for that reason that several of these individuals, because they were young and slim, were started on insulin, but after genetic screening, they've been able to come off insulin and go on to sulfonylureas, which is a dramatic advance for them. Finally, we see on the list MODY5, which is an abnormality in HNF1 beta. And this is associated with abnormalities of the urogenital tract, renal cysts, and also hepatic cysts. Strangely, they have abnormal LFTs and a low magnesium. It is rare, but it's rare to have that combination of diabetes and renal cysts. Sometimes they only have the renal cysts and not the diabetes within the family. So in this individual, we're thinking of a form of MODY, and in this case, MODY5. There are other forms, but they are particularly rare. Question 5. A 17-year-old girl with type 1 diabetes who's recently broken up with her boyfriend is brought to the emergency room by ambulance. Her parents say that she's become increasingly drowsy and confused over the past 12 hours. She's usually managed by basal bolus insulin regime, but examination of the hospital records reveals 2 previous admissions with DKA, and her most recent HbA1c was 9.5%. On examination, she's drowsy, confused and aggressive, and her GCS is 14. Her blood pressure is 95/65 and her pulse is 105 per minute but regular. She's apyrexial, respiratory rate 31 per minute. There's a vague abdominal pain on examination of the abdomen. Here are her initial investigations. And on to the question. You begin an infusion and appropriate IV fluid replacements. Which one additional therapy would you also instigate? And here are the 5 options. The preferred answer here is subcutaneous low molecular weight heparin. And this is an example of a common condition where they're trying to get at specific features. So let's go back to the question and the particular case. 17-year-old girl, type 1 diabetes. She's presenting unwell with drowsiness, and in the context of type 1 diabetes, we need to think of hypo or hyperglycemia. But she's had previous admissions with DKA, and she's got poorly controlled diabetes with an HbA1c of 9.5%. She's hypotensive, and that would fit with ketoacidosis. And she's got an increased respiratory rate, again consistent with acidosis. So when we look at the investigations, what we see here is that the white cell count, interestingly enough, is not raised, but the potassium is towards the upper limit of normal, as we might expect in this condition. Creatinine is raised, probably from dehydration. She's got a markedly raised glucose. This is clearly hyperglycemia, and she's got a low bicarbonate consistent with acidosis, and a pH of less than 7.3, in this case 7.2, consistent with potentially ketoacidosis. She's got a catheter specimen of urine with blood and protein, well, blood but no protein, and that might come from a traumatic catheterization. So when we come to the treatments, which one are we going to give? Well, you're probably familiar with the fact that even though she's acidotic, we're unkeen on giving sodium bicarbonate in this situation. There's been no evidence that this improves outcome. They can have a low phosphate, but in general that corrects itself when we treat the DKA. What about antibiotics? Well, in general we have a low threshold for giving antibiotics because infection, and in an older age group infarction, such as myocardial infarction, are often the drivers to DKA. But I think in this context they say that she's only got blood in the urine, she doesn't have a raised white cell count, there's no definite evidence of infection. Intravenous mannitol is used for cerebral edema, which happens in children. It's rare usually in this age group. She's slightly drowsy, but not markedly drowsy, and it often develops after the initial therapy. So that leaves us with subcutaneous low molecular weight heparin, and with the high glucose level, these individuals, like with hyperosmolar non-ketotic coma, are at increased risk of DVT and thromboembolism. So that's the appropriate response here by excluding the others. Let's look at some of the new guidelines around diabetic ketoacidosis. These have been recently introduced into the UK, but have been widely discussed. So I think it's very likely that several of these points will arise in the MRCP Part 2, where ketoacidosis is a common question. Firstly, in terms of diagnosis, we're now beginning to use blood ketone levels, which you may not be familiar with, since people are more familiar with urine ketones. So a normal level is below about 0.3 or 0.5, depending on whether you've been fasting. And ketoacidosis is defined here as a blood ketone level above 3 millimoles per litre. 5 is certainly a very high level, and you might think about it like lactate levels. 3 or 5 is a high level. And then defining the acidosis, a pH of less than 7.3. It's not based on the bicarbonate, but on the pH. Secondly, it's now acceptable to use venous pH rather than arterial blood gases to make the diagnosis and to monitor the acidotic state, and that includes measuring venous bicarbonate. And the main reason for that is that there's very little difference between arterial and venous levels. The arterial gas is used for the gases and not for the pH of bicarbonate. Thirdly, there's now a trend to continue the long-acting insulin. We used to always stop the insulatard or the levemir or the glargine, but now it's recommended to continue the long-acting insulin because it speeds the transition to subcutaneous insulin later. There's also a move to give fixed-dose IV insulin rather than sliding scale. So the suggestion is that you calculate the amount of insulin people need as 0.1 units per kilo, and you give that as a fixed infusion, and then when the blood glucose level falls below 14, we introduce 10% glucose. And the reason for continuing to drive the insulin is that the aim is to stop the ketosis. So we want to keep the insulin level going until the ketones have gone. We use saline to replace the volume. There's no indication for colloid, and that's been true for quite a long time. And then resolution is considered to be a ketone level in the blood of less than 0.3 millimoles per litre, and now the pH above 7.3. And that's the point at which you can switch the patient back to subcutaneous insulin. As we discussed in this question, we need to give subcutaneous heparin, and no indication for bicarbonate or intravenous phosphate. Question 6. A 73-year-old man comes to the clinic as a referral from his GP, having presented with severe headaches and ischemic pain in his fingers and toes. The pain increases with heat and improves if he keeps his hands and feet cold. Most striking is that just taking a few aspirin tablets seems to improve things for a significant period of time. He has a past medical history of hypertension for which he takes ramipril. On examination, his blood pressure is 142/87, and the remainder of the physical examination is unremarkable. Here are his investigations. And the question: which one of the following is the most appropriate way to deal with his hyperkalemia? 5 options for you to consider. And the preferred option here is C, recheck a fresh sample at the hospital. Let's go back to the case. So it's a slightly odd presentation. Ischemic pain in his fingers and toes, severe headaches. All of that is not typical of a condition you might think associated with hyperkalemia. There's nothing to suggest Addison's disease, for example, but he is on ramipril, which could be associated with hyperkalemia. Physical examination is unremarkable. When we come to the investigations, the striking feature, and outlined in the question, is a raised potassium of 6.2 with a slightly raised creatinine. But note also the raised platelet level. So it's important that you look through all the investigations. When we look at the possible answers, we've got stop the ramipril, that certainly could be an option. Start a small dose of furosemide, there doesn't seem to be any indication, and that's not a very good way of lowering someone's potassium. Start calcium resonium, potentially an option if we really thought he had persistent and maintained high potassium. Reassure the biochemistry department that it's related to the high platelet count. Well, in any form of high blood cell count, there is a risk of increased leakage of potassium. But before we become reassured, we need to check the sample again, because hyperkalemia, as you know, can be dangerous if untreated. So option C, of recheck a fresh sample at the hospital with a very low delay, very small delay, before the sample is spun down, is the best option here. What are the causes of hyperkalemia? So here I've listed them, and down the left-hand side, we're talking about artifactual causes, which are important to exclude initially before we go on to significant other causes, both common and rare. So what causes artifactually raised potassium? Well, a hemolyzed blood sample, and usually the biochemist will tell you that the sample is hemolyzed. But you also get it in myeloproliferative disorders, as here, this patient seems to have essential thrombocytosis. And in GP samples, which are sent overnight and unseparated, again, you can get a raised potassium from the sample being unseparated overnight. And in both these situations, potassium is leaking out of the cells and increasing the plasma or serum level. But of course, there are important causes of hyperkalemia when it's confirmed, the commonest by far being renal impairment, and also, as you see there, drugs, potassium-sparing diuretics, or ACE inhibitors, or excessive potassium replacement, particularly in the context of renal impairment. And metabolic acidosis itself can result in hyperkalemia. And rare important causes that we've listed down the bottom are hypoadrenalism. Very important not to miss in somebody who is hypotensive, as steroids could be life-saving. And an unusual cause that tends to occur in diabetes is type 4 renal tubular acidosis. Question 7. A 23-year-old woman is referred to the clinic by the emergency department having been admitted after fainting in the local supermarket. On further questioning, it transpires that she's been feeling weak and washed out for quite some time. On examination, her blood pressure is 105/60, pulse is 75. Her BMI is 18. She has calluses on her hands, but tells you that these are due to her job as a landscape gardener. Here are her investigations. And on to the question, which one of the following is the most likely diagnosis? And there's a list of 5 there for you to choose from. And the preferred answer here is laxative abuse. How did we come to that? Let's go back to the case. What do we notice in the history here? It's a woman. She's got a BMI of 18, which is a low BMI. And that often makes you think, in a young woman, of anorexia. And certainly it's something you need to be suspicious of. She fainted in the supermarket with a blood pressure on the slightly low side, but no other past medical history. She's been feeling weak and washed out for some time. The calluses on her hands, it's difficult to know, but it suggests that she does work hard and maybe there's excessive physical activity associated with that. Now let's look at the investigations. The striking feature here, most important feature, is a low potassium of 3.3. But what about the urinary potassium? And they haven't told us what the urinary levels of potassium should be, but in fact this is a very low level. And that implies that the potassium is not being lost through the urinary tract, not through the kidneys. So when we look at the options, we look at diuretic abuse, for example, well, that would result in potassium loss through the renal tract, through the kidneys. And that doesn't seem to be what's happening here. In Conn's syndrome also, you get increased potassium losses through the kidneys, and that would happen in Liddle syndrome and in Barter's syndrome. So what we have here is a low potassium, but we're having the potassium loss, it appears, from somewhere else. And that would fit with laxative abuse because diarrhea and vomiting would result in GI losses of potassium, resulting in renal potassium retention. So that's the conclusion of laxative abuse. Now let's look a little bit about the causes of hypokalemia. So across the top there you see the first cause, vomiting, diarrhea or fistulas, and diuretics. These are the common causes of hypokalemia. We saw that if the GI losses, the urinary potassium will be low. With diuretics, you'll also get a raised bicarbonate and you get an increased urinary potassium, typically more than 10 millimoles per day. There are rare causes of acidosis, renal tubular acidosis, ureterosigmoid diversion, which result in a low potassium, but unusually a low bicarbonate as well. That's an unusual combination. Then there's a collection of causes of mineralocorticoid excess, essentially too much aldosterone action. And Liddle syndrome mimics this, as does licorice excess or true Conn syndrome. But characteristically, these result in hypertension and a raised bicarbonate. And this lady was not clearly fluid overloaded or hypertensive, and her bicarbonate wasn't raised. There are unusual congenital syndromes, Gittelman syndrome, which is more common than people realize, usually an isolated low potassium, they're normotensive, but unusually, and it's often useful to test in this situation, they have a low magnesium level. Barter's syndrome is usually more dramatic, presents in the neonatal period, and has a normal magnesium. And then you can get intermittent low potassiums in rare conditions, periodic paralysis or thyrotoxic periodic paralysis, which is episodic, profound muscle weakness with a very low potassium, where the potassium has moved into the cells and it's not due to either renal or GI losses. And that concludes the last lecture in this series and gives me an opportunity to wish you all the best in the exam.